Hello, this is a video lesson on the procedures of the lower extremities. The projections we're to take a look at for the toes are the AP projection of the entire forefoot, the AP or AP axial toe, oblique toe, lateral toe, and the sesamoid specifically, which are tangential projections. We're to perform these all tabletop with no grid. So the AP or AP axial projection of the toes, some institutions may complete it may show the entire foot while others just show the image of the forefoot and others just show the toe or toes of interest. So what we're going to do is we're going to flex the knee. We're going to place the foot or the toes specifically on the image receptor, or you can place a 15-degree foam wedge under the foot if we're doing the axial. And we're going to adjust the image receptor with the midline of the parallel with the long axis of the foot. We're going to direct our central ray for the AP projection perpendicular to the third MTP joint. And if we are going to do an axial, we can either use a sponge or we can direct the central ray 15 degrees posteriorly to the third MTP joint. We're going to collimate 1 inch on all sides. And the AP axial is recommended to open joint spaces and reduce foreshortening. We're going to demonstrate the 14 phalanges, the distal portions of the metatarsals, the image interphalangeal joints, and the axial projections as well. So we're going to make sure that we get the entire toes and include the distal ends of the metatarsals. The toes should be separated from each other. There should be no rotation of the phalanges and equal soft tissue on width on and midshaft concavity on both sides of the phalanges. We should have open interphalangeal joints and metatarsal phalangeal joints on the axial projection. On the left-hand side is the AP projection where we see the joint spaces are not entirely open, where in the AP axial projection we can see where the dips and the pips and the ips are open. So the AP oblique projection with medial rotation of the toes, we're going to have the patient supine or seated, flex enough to put the plantar surface of the foot on the image receptor. We're going to position the image receptor under the toes, immediately rotate the leg and a foot, and adjust it to the plantar surface to form a 30 to 45 degree angle from the image receptor. We're going to center the toes to the image receptor as well. We're going to be perpendicular to the IR, entering the third metatarsal phalangeal joint, and we're going to have 1 inch of collimation on all sides. We're going to see the toes and the distal portion of the metatarsals rotated medially. Looking at the image, we should see something very different from the other projections we've talked about, besides the toes being separated, is that there's more concavity on the elevated side, just like you had with the hand. We want to see open interphalangeal joints to the second to the fifth digits. The first metatarsal phalangeal joint is not always open. On the lateral projection of the toes, we're going to do a lateral recumbent position. We're going to have the affected extremity, possibly use sandbags, and we're going to tape toes if we need to, or use some type of a tongue depressor. A 4x4 gauze pad may also be used to separate toes too. But never manipulate toes if a deformity is noticed. So we're going to rotate the affected leg medially for the first and second toes. We're going to rest the medial surface of the foot on the image receptor for the first and second. And for the third, fourth, and fifth, we're going to rest the lateral surface. We're going to ensure that the toe's in a true lateral position, and we want to make sure it's parallel with the long axis of the image receptors, the parallel with the long axis of the toe. And we're going to center to the IP for the first digit and to the PIP for the second to fifth digits. We're going to collimate 1 inch on all sides. So we're going to have a lateral projection of the phalanges of the toes and the toe, and the interphalangeal articulations projected free of the other toes. So looking at the image, the big toes, what we're showing is at the top up here. We're looking at being able to see the distal and the proximal phalanges. We've centered to the IP joint. We want to see the concavity on the plantar surface of the phalange. And then we can see on the third uh, digit that we're looking at the concavity also on the anterior surface. We want to see open interphalangeal joints as well, and the MTP joints are likely overlapping but can be seen in some patients. There are two tangential projections for the sesamoid bones. The Holly method is performed with the patient supine. The patient will place their heel on the image receptor. They're going to dorsiflex their toes using tape or a towel, causing the ball of the foot to be perpendicular to the image receptor. In the Lewis method, on the other hand, the patient is prone, and in this case, they're going to rest their great toe on the table in the position of dorsiflexion and adjust it to the ball of the foot perpendicular to the horizontal plane. In both cases, no matter either way, we're going to be perpendicular and tangential to the first metatarsal phalangeal joint. We're to collimate down to a 3 by 3 inch, and we're to get tangential projections of the metatarsal heads in profile and the sesamoids. So the sesamoids should be free of any portion of the first metatarsal in either projection. In terms of the foot, we're going to take a look at the AP axial, the medial, and the lateral obliques, the lateral, the AP axial weight bearing, and the lateral weight bearing. Again, these are performed tabletop with no grid. On the AP axial projection of the foot, we're going to have the patient in the same position as we did for the toes. Then we're going to have the plantar surface resting on the table. We're going to have the IR under the patient's foot and align the image receptor to the long axis parallel with the long axis of the foot. We want the entire plantar surface on the image receptor, and we want to ensure that no rotation of the foot occurs. The central ray is directed 10 degrees posteriorly toward the heel, entering the base of the third metatarsal. The AP axial projection is performed to reduce foreshortening, and the TMT joint spaces of the midfoot are better visualized. We're going to have collimation 1 inch on the sides and 1 inch beyond the calcaneus and the tip of the toes. In the AP projection, which is the dorsoplantar projection, is going to be visualizing the tarsals anterior to the talus, the metatarsals, and the phalanges. It'll be used to localize foreign bodies, determine locations of fragments in fractures of metatarsals and intertarsals, and even perform general surveys of bones of the foot. In the image of that we can see here, we're looking at there's no rotation because we want to make sure that we've got equal space between the second to the fourth metatarsals. There's going to be overlap of the second to fifth metatarsal bases, definitely. We're going to see that our axial projection will demonstrate our open joint spaces. Those interphalangeal joint spaces are open, and also the metatarsal phalangeal joint spaces are open as well. And there should be an open joint space between the medial and intermediate cuneiforms. On the AP oblique projection, which is on medial rotation, we're going to have the same positioning as the AP axial, except that this time we're going to rotate the leg medially until the plantar surface forms a 30-degree angle with the plane of the image receptor. We're going to center our ray to perpendicular to the base of the third metatarsal. We're going to use the same collimation that we did in the AP axial, and we're going to be looking at joint spaces between the cuboid and calcaneus, the cuboid and the fourth and fifth metatarsals, the cuboid and the lateral cuneiform, and the talus and the navicular. The cuboid, something important, is shown in profile, and also the sinus tarsi is well visualized. Looking at the images, we can see the cuboid shown in profile, and we can see that the sinus tarsi is well visualized. The tuberosity of the fifth metatarsal is also visualized on this image. Now there is overlap between the first and second metatarsals. The third to the fifth metatarsals are free of superimposition. In the lateral rotation, We're going to do the exact same oblique with 30 degrees. We're just going to rotate the leg laterally instead. We're to center to the same location and have the same collimation. This time our focus is on the joint spaces between the first and second metatarsals and between the medial and intermediate cuneiforms. So taking a look at here, we're looking at the joint space between the first and second metatarsals, and they're free of superimposition, and we're going to see minimal superimposition between the medial and intermediate cuneiforms. The navicular will have less foreshortening also in the medial than in the medial rotation. In the lateral projection, we typically perform a medial to lateral unless we're doing a cross table lateral. We're going to place the patient so that they're going to have their leg and their foot and their leg as lateral. And we're going to elevate the knee enough to place the patella perpendicular to the horizontal plane and put a sandbag to support under the knee. We're going to adjust the foot to the plantar surface is perpendicular to the image receptor. And we're going to center the image receptor to the midfoot and align the image receptor parallel with the long axis of the foot. We're going to dorsiflex the foot to form a 90-degree angle with the lower leg. So we're going to be perpendicular to the base of the second metatarsal in this case, and we're going to have the same collimation that we've had in the last 3 images of the foot. We're going to see the entire foot in profile. We'll see the ankle joint and the distal end of the tibia and the fibula. So we're going to see the entire foot and the distal leg. We're going to see the superimposed plantar surfaces of the metatarsal heads. The fibula is going to overlap the posterior portion of the tibia, and we're going to see the tibio-talar joint. In the AP axial projection for weight bearing, it's recommended that we use 48-inch SID to reduce magnification and improve spatial resolution. The patient is standing, they're upright. We're going to have the image receptor on the floor and have the patient stand on it with their feet centered on each side. We're going to have them pull their pant legs up to the knee level, and we're going to make sure their weight is equally distributed. We're going to use the same angulation we did for the AP axial for the foot, that's 10 degrees toward the heel. And we're going to ensure that we have the same collimation that we had previously. Now this is bilateral, so we're going to center between the two feet at the level of the base of the third metatarsal. And so we're going to see is weight-bearing AP axial projection of both feet to look at evaluation and compare the tarsals and the metatarsals of the feet. So both feet should be centered on the image. We can have the anatomy from the toes to the tarsals and include portions of the talus and the calcaneus. We want to make sure we have the right and left markers placement and have a weight-bearing marker as well. On the lateral projection, we are going to do a lateral to medial just for comfort. We're going to preferably have a low riser that has an image receptor groove. If not, we can use blocks or we can use the groove of a stool. We want a patient to stand equally with the weight of the body equally distributed on the feet. And we're going to center to the base of the third metatarsal and place the medial surface of the foot against the image receptor. We're going to center just above the base of the third metatarsal, and we're going to have the same collimation we've had previously. We're going to do a lateral to medial projection to look at weight bearing. We're looking at structural status of the longitudinal arch, and we're going to do both sides for comparison. So we're looking at the foot and the entire distal leg. We're looking at the fibula overlapping the posterior part of the tibia, and we can see the tibio-talar joint space. On the calcaneus, we have three projections: the axial projection planto-dorsal, axial projection dorsal-plantar, and then the lateral projection. We're going to perform this these projections tabletop with no grid. So the axial projection planto-dorsal is with the patient supine or seated and the leg is fully extended. We're going to have the image receptor under the patient's ankle and centered to the midline of the ankle. We'd like to have a piece of gauze or preferably like a Velcro strap or something around the foot to hold the ankle in dorsiflexion. If the ankle cannot be place it enough, flex enough, then we can elevate the leg on sandbags to correct the position. We're going to angle 40 degrees cephalad to near the base of the third metatarsal. We're going to have 1 inch of collimation around the sides of the calcaneus to include the fifth metatarsal base, and we're going to look at an axial projection of the calcaneus with the talocalcaneal joint and the sustentaculum tali in profile. So we're looking here at the calcaneus and the calcaneocuboid joint, the sustentaculum tali in profile on the medial side, and the first or fifth metatarsals not visualized on either side. Now there is an option for an axial projection dorsal plantar. This tends to not be as comfortable since the patient is prone and we have to build up the height of the leg in order so the person can dorsal flex the foot and have the toes on the table. We're going to place the image receptor against the plantar surface of the foot and position it in position with sandbags or a portable IR holder. We're going to position 40 degrees caudate this time and enter the dorsal surface of the ankle joint. We're going to have collimation of 1 inch on all sides of the calcaneus and include the fifth metatarsal base. And we're going to have an AP axial projection of the calcaneus and talocalcaneal joint. CT is often used to show this anatomy. And so we have the exact same type process, the same visualization process. I mean, everything visualized that we saw before. Here's this image is labeled, so I'll show you the sustentaculum tali to which we were referring before. We can see the tuberosity, and there's the lateral process on this image as well as the trochlea of the calcaneus. On the lateral projection, we're going to perform a medial to lateral of the calcaneus. We're going to turn the patient until they're lateral. We're going to adjust the calcaneus as it would be for a lateral foot and center to the image receptor. And we're going to direct our central ray perpendicular to the calcaneus, which is about 1 inch distal to the medial malleolus. We're to collimate 1 inch beyond the posterior inferior shadow of the heel and include the medial malleolus and the base of the fifth metatarsal. So we can see the angle joint in the calcaneus in lateral profile. Looking at the images that were shown here, we're looking at the entire calcaneus. The tuberosity is in profile, as we can see here. The sinus tarsi is visualized and is very open in this image. The calcaneocuboid and talonavicular joints are open. Now for the ankle, we're going to perform a number of different projections, starting with an AP. We're going to talk about the mortise, the medial oblique, which is a 45-degree medial oblique, the lateral, AP stress views, AP weight bearing, and then lateral weight bearing. These are all performed at 40-inch SID, and they're all performed at the tabletop. On the AP projection, the patient is supine or seated with the extremity fully extended. We're going to adjust the ankle joint in the anatomic position, and we're going to dorsiflex the foot. We're going to adjust the central ray to be perpendicular to a point midway between the malleoli. We're going to have 1 inch of collimation on the sides and 8 inches lengthwise to include the heel. So we want to see an AP projection of the ankle joint, the distal ends of the tibia and fibula, and the proximal portion of the talus. And it states here, and note that the inferior tibiofibular articulation and the talofibular articulation are not open or shown in profile in the true AP projection. This is a positive sign for the radiologist because it indicates the patient has no ruptured ligaments or other types of separations. For this reason, it is important that this position be anatomically true for the AP projection shown. So for this, we're going to have the ankle centered. We're going to see both the medial and the lateral malleoli. There's going to be no rotation of the ankle. We're going to see the talus also visualized on the image. And we're going to see normal overlapping of the tibia-fibula articulation, the talus overlapping the distal fibula, but there's no overlapping of the medial talo-malleolar articulation. We can see the tibio-talar joint space, which is shown here. The lateral projection, we're going to have the patient turn toward the affected side, which is very similar to the lateral calcaneus. We can do a medial lateral or lateral medial. It's more common to do a medial lateral though. So we're going to, for the medial lateral, we're going to make sure that the lateral aspect of the foot is in contact with the image receptor, where the opposite's true for the lateral medial. We're going to dorsiflex the foot and adjust it into a lateral position so we don't get the lateral rotation of the ankle. For the medial lateral, we're going to enter the medial malleolus. Makes it kind of nice as it's a spot that's easy to visualize. On the lateral medial, we're going to go 1/2 inch superior to the lateral malleolus. We're going to see a true lateral projection of the lower third of the tibia and fibula, the ankle joint, the tarsals, and the base of the fifth metatarsal. So we're looking here at the ankle in the true lateral. We're going to have the fibula over the posterior half of the tibia. AP oblique projection, medial rotation, Mortise joint. So this is an oblique projection with the medial rotation of 15 to 20 degrees. And we're going to internally rotate the foot until the intermalleolar plane is parallel with the image receptor. We must again dorsiflex the foot to place it at a right angle to the leg, and we're going to center midway between the malleoli. We're going to use the same collimation we did for the AP projection, and we're going to see the entire ankle Mortise in profile. The 3 sides of the Mortise joint should be visualized. So looking at this, we're looking at the talofibular articulation is open, as well as the tibiotalar articulation is open on 2 sides. On the AP oblique projection, medial rotation, this is a 45-degree medial oblique. We're still going to dorsiflex the foot to 90 degrees, and we're going to have our beam perpendicular to the ankle joint, entering midway between the malleoli. We're going to have the same collimation we did previously. We're going to see the distal end of the tibia and fibula, and the parts of which are superimposed over the talus. The tibio-fibular articulation should be shown. The proper 45-degree rotation of the ankle for this medial rotation is best visualized by looking at the tibiofibular articulation being open. Taking a look at the AP and the 2 obliques to which we've discussed, the AP projection, we do see a complete closure of the tibia and the fibula. There's no opening. Plus, there's a lack of opening of the tibia and the talus, the superior portion of the talus. On the medial oblique with 15 to 20 degree rotation, we see the intermalleolar plane is now parallel with the image receptor. So we've opened and we can see the Mortise. We can see the opening between the talus and the fibula and the talus and the tibia. On the AP oblique medial rotation with 45 degrees oblique is where we're going to see the tibiofibular joint is open. The AP projection stress method is one in which is the same as the AP projection. However, this is going to be used to verify presence of a ligamentous tear. Rupture of a ligament is best shown by widening of the joint space on the side of the injury. An orthopedic surgeon may inject a local anesthetic into the sinus tarsi prior to the exam. The physician will stress the ankle in extreme inversion and eversion positions. And the image on the left-hand side is the neutral, and then we can see the eversion and the inversion positions. The AP projection of the ankle with the weight-bearing method is going to identify joint space narrowing of the ankle. It's going to be an upright position, preferably on a low platform that has an image receptor groove, and ensure the patient has proper support. The image receptors should be placed in the groove of the platform or between the blocks, and you want to have their heels pushed back against the image receptor with their toes pointing straight ahead toward the X-ray tube. You want to have the central ray perpendicular to the center of the image receptor, and so you're going to have the central ray midway between the ankle joints. and we're going to have the collimation 1 inch outside of the shadow of the feet, but not beyond the image receptor borders. And we're going to have this so it's 8 inches vertically to include the heel. So we're going to have an AP projection of both ankle joints and a relationship of the tibia and the fibula with weight bearing, and it also shows side-to-side comparison of the joint. So taking a look at the images, we've got the medial ankle mortise open, where again, we're looking for joint space narrowing. The lateral mortise should be closed. The final projection is the lateral weight bearing, and this is for another upright position, image receptor between the feet, and we're going to do a lateral to medial, and we're going to do these bilaterally. So we're going to center to the ankle joint, entering a 1/2 inch superior to the lateral malleolus. We want the distal tibia and fibula superimposed, and the ankle joint should be in profile. In this particular evaluation criteria, we want to make sure the ankle is in a true lateral projection in which the fibula is over the posterior half of the tibia. We want the tibio-talar joint well visualized, and the medial and lateral talar domes should be superimposed. The images should be very similar to the lateral projections, except for this is weight bearing, so we're looking for joint space narrowing. This concludes our video lesson on the first part of the lower extremity procedures.